We're going to go on to talk about some of the technical aspects of addressing the radius deformity. Chai did an excellent job of addressing the discrepancy in length between the radius and the ulna. At the end of the talk, we should understand which malunions require reconstruction, and we've heard a good bit about that, so I won't belabor that too much. We'll understand how we use radiographic imaging in preoperative planning for our osteotomies, and we'll develop treatment strategies with exposure based on the needs of the patient and on minimizing morbidity from our surgical procedure. We'll learn how to perform a volar osteotomy of the radius and the approach for that, and we'll talk about the same for a dorsal osteotomy of the radius. What is the best way to approach radial malunions? As we've heard, not all malunions require treatment, and there are a number of factors that go into deciding who is best helped. When they do require treatment, is it best to approach them dorsally, volarly, or do we need to approach both the dorsal and the volar components separately? Well, I think first it's important to understand why patients require osteotomy in the first place. First and foremost, there's mechanical alteration in the radial anatomy which produces dysfunction. And there are a number of features, we've heard about them a bit. Loss of volar tilt will affect the flexion extension arc of the wrist and the range of motion. Radial angulation and shortening can affect distal radioulnar joint incongruity, create impingement, or even instability when it's combined with significant ligamentous injuries on that side of the wrist. Altered radial slope and translation of the distal articular surfaces can affect radial and ulnar deviation. And finally, loss of a smooth articular surface can produce arthritis. Pain is often associated with the deformity and is another primary driver for determining whom to operate on and when to perform surgery. And finally, visible deformity, although it is not considered a functional deficit, can often be quite profound and is in many cases the most bothersome component of these injuries to the patient. Apex volar angulation with loss of volar tilt can affect wrist flexion due to alteration of the radiocarpal joint line, and here we see the typical dorsally collapsed fracture due to metaphyseal comminution that goes on to heal with this shortened and dorsally angulated malunion, and you can see that the normal 15-degree volar tilt has now been translated to about 20 to 25 degrees dorsal tilt, and this patient is going to run out of flexion very quickly if they can flex at all. This also alters the load bearing of the carpus and creates adaptive mid-carpal instability due to shift of the load forces on the lunate and radius, and this can lead to arthritis. And we see that here where you see the capitate starting to impinge on the dorsal lunate as the lunate is tipping a bit and subluxating dorsally. So it's important not just to consider the radius in determining which malunions will require and will benefit from surgery. Shortening and angulation, as we've just heard from Chai, can affect the DRUJ. It can uncouple the ulnar head and the sigmoid notch, which can lead to limitations in pronation and supination and symptomatic impingement. And the associated ligamentous disruption can lead to instability and pain. And I have a short video of this patient on the right. And Mackenzie, if you can run that for us. And this is the typical instability test where you have the patient pressing straight down toward the floor on their pisiform. And you can see the gross instability in the ligament. This was a patient with a radial malunion after an earlier ORIF performed elsewhere where they just did not get the distal radioulnar joint at all well seated and also didn't identify the extent of the ligamentous injuries. So these need to be treated because it's a painful and functional deficit. If we could go back to the lecture. But finally, I want everyone to take home as a message today that you really can't underestimate the impact of the deformity to the patient. We focus so much on radiographic changes and on functional incapacity, but patients are often very troubled by these deformities, and you can see three characteristic examples here. So we have to consider that as a criterion in and of itself for correction of these malunions. Preoperative imaging always includes standard views of the radius on plane radiography, PA, lateral, and oblique. It identifies changes in volar tilt, radial length, and we can identify translational deformities. You can see widening of the DRUJ and often dorsal displacement. On this image, which I'll highlight here, we can see the pretty substantial length discrepancy between the radius and the ulna. There was significant shortening in addition to dorsal collapse and tilt. And here we see uncoupling again with widening of the DRUJ. So it's tempting to focus most of your attention on the radial defect itself, but it's really, as Chai said so eloquently, this is a three-joint deformity, and we have to consider all of them in concert as we plan our treatment. In my hands, CT scan is really a critical element in evaluating almost every malunion that I'm considering reconstructing. The plain films often belie the three-dimensional nature of the deformity, and the CT scan can really give you a roadmap for reconstruction. It identifies intra-articular displacement much better than X-ray, and it's very useful in complex fractures where we have multiple displaced fracture fragments that have healed. And here we see a fairly easily identified step-off in the volar lunate fossa. You can see a little bit of palmar and proximal migration of the lunate due to this step-off, but you don't really know, does this go all the way across? Is this a uniplanar deformity, or is this a three-dimensional deformity where there's a coronal component as well as the sagittal component? And really the only way that we're going to get information about that is with the CT scan, which we got. So we can appreciate much better the three-dimensional nature. This does not go from volar to dorsal all the way across the radius. It goes into the sigmoid notch, and you can see flattening of the normal curve of that notch, and this is going to affect not only radiocarpal motion, but also distal radio-ulnar joint motion because of that loss of translational rotation of the ulna. That's really well shown here in the 3D reconstruction as well, where you can see that component coming across into the DREJ, and you can see the palmar displacement of the lunate due to the loss of the facet height. So again, CT scanning is really critical in identifying these fractures. Once we identify the fracture thoroughly, why would we do a distal radius osteotomy? Well, it's really appropriate for all malunions to some extent, and we need to determine which patients are going to be best helped. It corrects all of the radiographic parameters. It can restore proper carpal mechanics because, as I just mentioned, this is not just affecting the radius, it affects the mechanics of the radiocarpal and intercarpal joints. There's certainly ample evidence that it works well, and it's a lot easier to explain to a patient who knows they broke their radius why we're going to address the radius instead of the other side of the wrist that they didn't injure. So it makes sense to patients that they broke their wrist, that didn't heal properly, and we're going to correct the broken bone. Once we decide to do that, is it best to approach these from a volar or a dorsal exposure? Well, we all know from treating the primary injury that volar approaches generally are better tolerated in terms of irritation from the hardware if we go on the volar side. Extra-articular correction of tilt, length, and slope is easily achieved through the volar approach, even with a lot of dorsal shortening, because of the success of using variable angle locking plates. We can really correct that angle even from the volar side when there's a lot of dorsal shortening. And metaphyseal malunions and volar ulnar corners can be approached from a volar exposure. However, dorsal exposures are still appropriate and are still necessary. Intra-articular displacement in malunions is best approached dorsally. We really can't and shouldn't expose the volar joint unless we're looking only at that volar rim itself. And we can also combine an open exposure to the DRUJ and the TFCC when necessary if there's gross instability, as in that video that I showed where the patient is going to need some ligamentous stabilization in addition to correcting the radial deformity. And when we do have large opening wedge osteotomy defects, if they're quite large, and as we'll hear a little bit later on, if the volar cortex is no longer in communication, then we'll need to graft that. And sometimes with a large dorsal defect, it's just not possible to get a good bone graft in there from the volar side. So you should always reserve the right to go dorsally and counsel the patient that you may need to go dorsally if you have to bone graft a large defect. The volar surgical exposure is pretty well understood by all of us from treating primary injuries. There's a longitudinal incision over the FCR. We track the FCR to expose the plane down to the pronator quadratus, and you release the pronator. And then you want to limit the dissection whenever possible to preserve the bony origin of the volar ligaments, which is here. We don't want to go distal to that and detach them and create dorsal volar instability in the carpus. It's a standard exposure. I like to then insert K-wires parallel to the plane of the joint, and that allows us to then create the osteotomy in the joint plane so that we can then correct that by tilting it, and you'll see that graphically in a minute. So these are just guides that I use. I make sure that once I put these in and I get some fluoroscopy in the operating room, the plane of these pins is exactly parallel to the joint, and then I know I'm going to restore the normal tilt once I bring that back after my osteotomy. Use dorsal tissue protectors to protect the extensor tendons, the first extensor compartment, and the radial sensory nerve. And then I like to apply the volar plate distally first, and you can see this sticking up out really of the incision here, so that as we bring that back down to the radial shaft, once this is secured and we've gotten fluoroscopy to be sure our pins are where they should be, this will then correct that dorsal collapse and give us a nice volar tilt again. And you can see that achieved here. That creates a dorsal defect, which in this case we had good volar continuity and I did not feel a need to graft it, and Chai's going to talk about that a little bit later. So this is a graphic depiction of that. Here we can see the determination of the initial angle off of volar tilt, and this was determined to be 32 degrees. And here you can see the plate in its planned position. Here we see the plate fixed to the distal fragment first, and the osteotomy is going to be right through here. You can actually do this with the plate in place. I prefer not to do that. I don't like to saw into the plate, but if you're careful, you can saw right up to it, leave the volar cortex intact, and then just crack it. And that's done here. And then finally, you can see fixation of the plate to the cortical shaft, which creates the opening wedge defect, correcting that angle and restoring volar tilt. So this is a good graphic depiction of that technique. Not all of them are as simple as this, and they don't always occur in the coronal plane. Here we see quite a displaced osteotomy, or quite a displaced malunion requiring an osteotomy, and the question is, what needs to be corrected? So we can see that radial slope, length, and volar tilt have all been affected by this multiplanar defect. There's still some dorsal comminution with some reorganization, and you can see the impact this has on the DRUJ. There's been an ulnar head fracture, and you can see the deformity that this produces, and there's incongruity of the distal radio-ulnar joint. So we approached this volarly, and the osteotomy was performed in such a way to allow us to correct all of those deforming forces. The osteotomy was an oblique osteotomy parallel to that radial surface again, but in this case it was not dorso-volar, it was primarily radio-ulnar. That allowed application of a fixed angle plate, and again, this is not the plate we would select today, but this was 10 years ago when the plate selection was a little bit more rudimentary. It still did the job, and then we rotated that plate around. So initially, the plate was put on with the shaft coming off in an ulnar direction like this, because the radius was really sitting down here. As we used the plate to then lever out that radial articular surface until we restored the slope and the length, that created quite a large defect with really no continuity on the ulnar side. There was no cortical continuity between these two segments. So a corticocancellous iliac crest bone graft was inserted for structural stability, and then the whole construct was stable. And it really corrected the deformity quite nicely. This patient, as you can see, went on to do very well. Here she is at a year and a half after the osteotomy, fully healed and quite happy with, obviously, her deformity correction, but she has quite acceptable function as well. So these multiplanar deformities are correctable through a volar approach. The volar ulnar corner malunion with carpal subluxation, and again, I think these are really important to assess not only in terms of what's happening to the radius, but to look carefully and critically at what's happening to the carpus. And we can see volar subluxation due to this displaced volar corner, and you can see that here. Again, as I said initially, I really like to get CT scans to help plan these. You can see that there's a step off of some sort, and you can see the impingement that results from the sagittal plane or the coronal plane displacement, where you get now that sharp edge of the remaining dorsal fracture impinging on the displaced lunate, and it's quite painful. So in order to better evaluate the three-dimensional characteristics of this, a CT scan was obtained with three-dimensional reconstructions, and that gives us a much better ability to direct our osteotomy, which here came into the distal radioulnar joint and not simply going dorsovolarly to mobilize that fragment. Here we see the same patient, the volar approach, same exposure. It does not have to be as extensile because we're really only dealing with that one corner. We can correct the lunate subluxation and use fragment-specific plating. So this is a three-dimensional, it's only partial thickness of the radius at the articular surface. It came up into the joint so that we did not disrupt the dorsal cortex, and that left a void, which was in this case grafted with cancellous allograft to simply fill in the dead space, and healed quite nicely, restoring that. And again, pay particular attention in these to the radiocarpal alignment, which we can now see has been restored, and that palmar subluxation has been corrected as we've propped up and secured that volar lip. Not all of these are going to be approached volarly, as nice as that would be. And the dorsal approach is the standard approach we use for dorsal exposure to the wrist and the distal radius. It's between the second, third, and fourth compartments, mobilizing the third and then elevating the second and fourth. The compartments are labeled to the left. And then I like to use a ligament-sparing dorsal capsular flap as depicted in that central image. And here you can see an example of a larger opening wedge osteotomy dorsally packed with cancellous iliac crest bone graft before plating. You can even fill this dorsally and then go ahead and put a volar plate on if you want to, but the patient's going to have to accept a dorsal and a palmar incision for that. But not all of the osteotomies can be performed volarly. And here's a good example of why. So this is a patient with a complex intra-articular malunion. We're going to look at this same case a little bit later in my next talk. But you can see that it's really the only opportunity we have to directly visualize the joint surfaces by going dorsally, flexing the carpus, and getting a good look at the articular surface. And you can see again a three-dimensional defect. There's a coronal plane here, a sagittal plane here, and then this articular surface was rotated almost 90 degrees proximally. And this has to be addressed dorsally. You just can't get there from the volar exposure. In summary, both volar and dorsal approaches are useful, and it's important to know when to use which approach. The volar approach is best for extra-articular malunions and volar rim osteotomies. The dorsal approach is used for intra-articular malunions, and when we need concomitant exposure of the DRUJ and the TFCC, I almost always use CT scanning in helping to plan my osteotomies. We're often surprised at seeing different planes than we expect in these malunions, and it's really the only way to see the small fragmentary components of the malunion so that we can make our osteotomies more accurately. Mechanical alteration with dysfunction, pain, and deformity are all appropriate indications for osteotomy. I've provided some references which you'll have in the downloaded segment after we complete the webinar, and I think these are all great papers going over some of the basic principles.